In February 2025, we ran a webinar called Getting the Most Out of Consultations. So this is part 2, where we discuss the active monitoring phase and we answer questions from webinar delegates. There's a couple of images here which will act as a springboard to our conversations about moving into the active monitoring phase. And there's discussions on prehabilitation. This was a project we embarked upon with AbbVie. So these images are courtesy of AbbVie. A number of us and others took part in this project, and it's called My CLL Life. And there are quite a number of resources available, and the website is myclllife.co.uk if anybody wants to go and look at it. And it has some videos, it has testimony from patients, but one of the images in the booklets was the second panel on the right there. So taking care of yourself during active monitoring, considering your treatment goals, and deciding on the treatment with your doctor. So I think this is one of the things which CLL diagnosis and active monitoring and beginning to come to a point where treatment is on the horizon and you get an option, which, you know, typically from a patient's point of view, especially a patient of, significant years, it would be classically doctor knows best. And, you know, what you tell me what treatment, when it's about to happen, and, you know, I'll turn up and look pleasant. But that's not the case, because there is a thing called shared decision making, which we'll talk about in the next section. But taking care of yourself during active monitoring, we recently had the webinar on exercise. Maggie's have a program now called Prehabilitation. And so maybe, Andres, would you like to talk about the active monitoring phase and how you deal with patients and the frequency of consultations?
So with active monitoring phase, there will be mixture of approaches dedicated by patient needs. And proportion of patients who are very stable, and when we're not expecting any concerns over the decades, we're asking our colleagues in primary care for interval full blood count monitoring and contact hematology team through the advice and guidance system. We've got nurse-led telephone clinic, virtual clinics, and patients who, as clinicians, we believe they may be approaching treatment maybe sooner than later. We tend to keep them in consultant-led clinics, again with interval bloods monitoring and face-to-face assessment. The concept of active monitoring and that balance move towards the patients, and more and more we would like to see patient-initiated follow-up. When the patient is well educated, aware of the symptoms of concern, and alongside of blood monitoring schedule, patient is aware of the symptoms to look for. And that will be what we call B symptoms, so unexplained weight loss, drenching night sweats, or unexplained fevers, or rapidly growing large volume lymphadenopathy, so enlarged lymph glands. And the other advice to the patients is really look at your normal pattern and see if anything start happening outside of your pattern. If you look in the mirror and you see something is not to your normal view, or the tasks you taking on daily basis, you are unable to finish, something has really changed to your normal pattern. That would be question, is that possibly related to CLL, or the reason might be completely different? but that might be the point of reassessment. And at that that moment will be contact the clinician and reassess. Yes.
Right. Okay. So you're getting kudos there, David, for using the word careful monitoring. That has been voted as being very appropriate and much better than watch and wait and active monitoring. So well done there.
I think the other thing to say about the active monitoring phrase or careful monitoring, one of the things that we think about again is infections. So one of the things that we will pick up on is ensuring that people have all the vaccinations that you're offered. I think you probably dealt with this in a different webinar, but
Yeah.
very important that people are up to date with influenza and coronavirus vaccinations, that people are initially vaccinated against pneumonia, and that when and that if offered the shingles vaccine, that they accept those. There is a slight degree of uncertainty as to how well vaccination works in persons with CLL compared to persons that don't have CLL. But certainly they have a big impact, and they are all safe and effective. Any stories people may have come across sort of linking vaccination with other health problems, it's just not the case. They are safe, effective, and for people with CLL, some of whom may have more frequent infections, they're a very, very important part of follow-up, and it's something that we regularly pick up on in our consultations. And then if people during them, you've got sometimes you can have stable CLL, but CLL can do something sort of quite odd to the immune system. So you can have CLL that there's no lumps and bumps and all the blood counts are normal or stable, but it can do odd things to the immune system. And sometimes we'll send people on to our colleagues in immunology, who can then either offer antibiotics if infections are difficult, or sometimes you can have an infusion of something called immunoglobulin, either given into the vein or under the skin. And for selected people, that can make a difference if they're having troublesome recurrent infections.
That's interesting. You brought up that because that's one of the questions or one of the comments in the Q&A. From my perspective as a patient, I feel that making sure my vaccinations are up to date, being aware of my immunocompromised state, the fact that I'm susceptible to infection, and making reasoned judgments as to how I protect myself from infections, crowded spaces, public spaces, whether or not I decide I want to go for a swim or not, and that all depends. Of course, during the winter, that's another issue because we're much more infection seems to be going around, and a lot of us will have grandchildren. And the fact that they are complete and utter bug factories when they, love to hug them, but it can potentially come with a cost. One of the questions which is been brought up here is, and I'll just read it out directly. My initial consultation is still in the future, so that's interesting. Having MBL, my lymphocyte count has reached the level set by hematology for referral. My question is whether I can expect a diagnosis on my second visit after blood tests and not on my first visit. So, okay, that's a little bit specific, and we always say that we can't give very specific medical advice because we don't know the patient's background. But in general terms, would one of you like to respond to that?
The person that posed the question will be seen by one of our colleagues in whichever part of the country they're in, and then an assessment will be made as to how much the blood has changed compared to the prior diagnosis of MBL. The specialist may or may not feel the need to repeat the initial test that found the MBL. So the difference between MBL and CLL, it's a question of numbers. So it's how many of the abnormal cells are present in your blood. And if you're slightly below the level, you've got MBL, and if you're slightly above it, you've got CLL. But the actual cells are the same. So they may or may not get the the diagnosis reassessed, and then a plan will be based around the blood counts that are present and how the person is. So as you say, difficult to be specific. Everyone like myself does something slightly different, but it be an assessment based around how the person is and what the bloods are at that point in time.
So we have another question, and it's again, I'll read it all out. Hematology discharged me as 3 years on. My CLL is stable. Initially, I asked for a consultation with my GP when my CLL would be reviewed, and the GP said at my annual review. At my annual review in December, I asked the nurse the question about lymph nodes, and she said it was out of her remit. It's now 18 months since my last CLL review. Should I be asking my GP to review me back into a CLL clinic, I presume?
I can see how that would have produced some anxiety for the person posing the question. Again, it's difficult to give specific advice. Generally, we advise the frequency of assessment is generally based around how likely or not it is that that person's CLL will progress, and there's ways you can get an idea about that. But generally, we would recommend checking the blood every 6 to 12 months. In some parts of the country, primary care can do that. In other parts, as we've said, Andreas or Debbie would do it. The question of checking for lymph nodes. So treatment for CLL is essentially indicated if person has symptoms, if it's making them feel unwell, or the CLL is clearly progressing quickly, which generally is associated with symptoms. So in terms of regular checking of the lymph nodes, it's not something that we necessarily do each time. If someone feels well, they haven't got any symptoms related to enlarged lymph glands, you're having a telephone consultation, sort of regularly digging around with sort of cold, spiky fingers, can you feel a lymph node? Can you not? In a way, if you feel well, it doesn't really matter too much. It's all the overall picture. If you've got concerns, so if you notice a lump under your arm that's getting bigger, or you've got a discomfort in the neck, then you need somebody to physically examine you. So I don't feel that regular physical examination is necessarily required. Probably blood monitoring every 6 to 12 months with a discussion about what the bloods mean with somebody, and that can be done, I say, primary care hospitals or nurse specialists or other teams.
So it's quite a number of years since I was at the initial stages of my old CLL story. And can you just walk us through the sequencing of tests during active monitoring? And let's say the bloods are beginning to show some movement in a direction that we don't particularly like. So, the FISH testing and bone marrow and scans. I honestly, I'm not aware exactly when they are done and in what sequence.
In general, we monitoring trend and having some series of blood tests. We see how they're changing and what is most important and what is the dynamic of change. We keeping eye on the lymphocyte count, but also what is even more important from hematologist perspective, what's happening to hemoglobin level, what's happening to platelets count, whether the other blood cells are compromised by increased number of lymphocytes. And if we see there is a degree of worsening anemia, thrombocytopenia, this is a signal for us that treatment intervention is approaching. Regarding the lymphocyte count, we often seeing completely asymptomatic CLL with quite impressive white cell count, getting well in excess of 100 or even 200, whilst patients still remains asymptomatic with preserved hemoglobin, with preserved platelets count, when we still will be in the careful monitoring stage. When we doing the prognostic markers, the prognostic molecular markers, It's usually at the case when we considering treatment interventions. So just before introducing treatment, we tend to have all up-to-date prognostic markers, not really necessary at the initial diagnosis. The reason for that, the CLL sometimes undergo clonal evolution. So the clone of cells which has been present at the initial diagnosis may acquire additional molecular features, and it's more important and more beneficial to test them just before commencing the line of treatment.